name is Nichole Michaeli. I'm an emergency physician at the University of Vermont, and today I'm going to be talking to you about infectious diseases of Central and South America. I did my Global Emergency Medicine Fellowship at Harvard Medical School and Brigham and Women's Hospital, and during my time there, I had the opportunity to do a diploma in tropical medicine and hygiene with the Gorgas course in Lima, Peru. So a lot of the cases that we're going to be covering today are from that course, although most of my expertise, I will say, is in sub-Saharan Africa. I have no disclosures related to the content of this course and hope to do justice for the work that's being done by my wonderful colleagues in Central and South America. We are going to go through and highlight a number of different parasites, viruses, and then also one bacterial infection that are common in Central and South America. And there are a lot of infectious diseases in this region of the world. There's also a large burden of neglected tropical diseases. So those are the ones that aren't getting those research dollars and aren't being widely studied. Some of those that we're going to cover today are on this list. And there is a disproportionate burden, particularly among Chagas disease and dengue, as well as leprosy in this area of the world. There are a lot of different things that we're not going to have the time to cover today in any kind of detail or even mention, but wanted to throw this up there just to remind you that there is a large burden of neglected tropical diseases in this region of the world, particularly in Brazil. And the way I've set this talk up is we're going to go through a number of cases. I'm going to present the case and then we're going to talk about the management of that case, the treatment, and how you would work them up if they came into your emergency department. And so we're going to start in the Amazon region of Peru with a 5-year-old boy who's coming in with 5 days of fever, chills. He has a headache, some malaise, dark urine, no cough though. On exam, he's febrile, he's really pale. You see this conjunctival pallor. He's also jaundiced and has splenomegaly. And then when you get some labs back, you notice he's anemic, he's thrombocytopenic, and his bilirubin is elevated. And so if you see a child or you see anyone who has a really high fever for just a few days with a lot of pallor as well as that elevated bilirubin and maybe splenomegaly, I want you to think about malaria. And malaria, while we predominantly think about it as the infection in sub-Saharan Africa, is actually quite prevalent in Central and South America. Plasmodium vivax is there as well as falciparum, and then rarely you will also see malaria in O Valley. Plasmodium vivax is going to be the most common, and that's going to represent 70% of cases of malaria in Central and South America. It's going to be prevalent in Brazil, Colombia, as well as Venezuela. And if they come into the emergency department and you think that you can manage them and discharge them in the outpatient setting, you're going to treat these people with chloroquine. That's going to be your first line. However, if you're not confident that it's Vivax and it could be falciparum, you can also treat them with ACTs. I would prefer treatment with ACTs in this setting because there's a lot of resistance to chloroquine, particularly among Plasmodium falciparum. Also want you to think about primaquine. That's going to clear those hypnozoites, which is what causes the relapse of malaria in these people who have this infection. So this is the map, once again, just highlighting where there is that prevalence throughout Brazil, Venezuela, and Colombia. And then this graph shows that those hypnozoites that are hiding away in the liver. And so while in malaria, we often think about that parasite getting into the red blood cells. That's what causes that remitting, relapsing fever. You also are going to have those hypnozoites in Vivax that hide out in the liver, and that's going to cause those relapsing infections weeks to even months later. And so unless you treat that person with primaquine, which unfortunately is contraindicated if anyone has G6PD deficiency, you're not going to be able to clear those, and they're going to get those reinfections from time to time. Plasmodium falciparum is also common in this area. It causes about 25% of malaria cases in Central and South America in the same areas that we saw Vivax, but the treatment for this is just going to be the ACTs. There's too much resistance to chloroquine to use that to treat Plasmodium falciparum. It is much less common. You see that the range is much less widespread on this map, but there are some isolated pockets, and I do want you to think about this. Plasmodium falciparum is also going to be more likely to be responsible for severe malaria. And so severe malaria, these are the patients that you want to be looking out for and want to admit to the hospital. These are the ones that can get really sick. So anyone with has altered mental status, seizures, if they have respiratory distress or shock, any signs of organ failure like kidney failure or liver failure, if they're jaundiced or anemic, With children, you can especially see a lot of hypoglycemia. You also see thrombocytopenia and bleeding. And then anyone who has a high parasitemia, which is a red blood cell count greater than 5% of red blood cell, or sorry, a parasite count in the red blood cells representing parasites that are infecting more than 5% of the red blood cells, you want to admit them to the hospital. And so on this slide here, you can see this is a thin smear, and there's very obviously more than 5% of the red blood cells on the smear have those ringed parasites in it. And so you would want to admit that person. If they're coming in and they need admission, they need IV treatment. So that's going to be primarily with IV artesunate. That's going to be your first line, followed by IV quinine or IV artemether if that's what you have available. You also want to think about your supportive care, so giving dextrose to patients who are hypoglycemic, transfusing patients who are severely anemic. I've seen hemoglobins as low as 4 in children with malaria. Give benzodiazepines for your seizures. Be careful about your fluids. If they have an AKI, go ahead and give them fluids. If they're in shock, give them fluids, but just be aware that this can progress to pulmonary edema. Patients can develop that, and so be really cautious and give pressors if you need to. I put this rapid test up here just to highlight. You want to know how your technicians are testing for malaria where you're working. They might be doing it on thin and thick smear. If you have an experienced technician, they're going to be able to easily distinguish between falciparum and Vivax on that smear. But if you don't have an experienced technician, if they're not using microscopy, if they're using these rapid tests, you want to know what they're actually testing for. Some of these tests, like this one, test for falciparum and ovale. And sorry, first falciparum, Vivax, and this one also tests for ovale, and it looks like malaria too. But some of them are just going to be testing for Vivax. Some of them are just going to be testing for falciparum. So you don't want to miss something because it's not getting tested for. So with that said, we're going to move on to our next case where we're going to be in rural Bolivia. And in the emergency department, when you're working in rural Bolivia, you have a 9-year-old boy who comes in with 5 days of fever. He has this swelling around the left eye. He's febrile. He has some conjunctival injection. You see hepatosplenomegaly and a rash. And then his laboratory studies show this lymphocytosis and elevated liver enzymes. And this sign is pathognomonic for Chagas disease. This is called Romagna sign. And Chagas disease is caused by a parasite known as Trypanosoma cruzi. The vector is going to be the triatamine bug, also known as the kissing bug. And this is going to be transmitted when the bug bites an individual and then leaves feces into that wound. And that's how the parasite gets into the body and into the bloodstream. This can also, however, be transmitted via food. So if these insects are in the food and the feces are contaminating the food, you can get it that way. And it can be spread congenitally as well from mother to child. This is the global prevalence, map showing global prevalence of Chagas disease, and you can see it really is isolated to the Americas, with Brazil unfortunately having the greatest burden of that prevalence. It is endemic to this area, and there are about 6 to 7 million people that are affected globally. Chagas is divided into different clinical presentations based on the acute phase versus the chronic phase. So in the acute phase, which represents those first 2 months, a lot of patients are going to be either asymptomatic, so you're not going to see them, or they're going to have really non-specific findings like fever, headaches, a lymphadenopathy, some pallor, muscle pain, abdominal or chest pain. If you see a chagoma, which is this like raised bite where the insect bit, or you see that Romagna sign, I want you to think about Chagas. But a lot of times this really, you need to have high clinical suspicion, really need to be thinking about this to even test for it. If it is not caught in this acute phase, what happens is the parasite hides within the heart and the digestive muscle in the form of something called a mastigote. And these can remain dormant for years before they actually cause damage through just inflammation in this area. And this can turn into this chronic infection about 10 to 30 years after infection, in which about 30% of patients will have a dilated cardiomyopathy, arrhythmias, and can develop heart failure. And about 10 to 15% of patients will get the digestive form, which can result in megaesophagus and megacolon. This can also, Chagas disease can also be reactivated in immunosuppressed patients. And so you can see high levels of parasitemia in patients who maybe develop HIV or another form of immunosuppression. And this can present as an acute myocarditis and meningitis or encephalitis, as well as more disseminated skin lesions. The diagnosis during the acute phase is going to be made on peripheral blood smears where you're going to see those trypomastigotes. You can also detect this on PCR, but this might not be available where you're practicing. And then the chronic infection is going to be by serology, detected by serology or PCR. You can also detect the infection using something called xenodiagnosis, which is what is shown in this image here. And it's really, really interesting way of detecting an infection, and it's still used in some of the places on the continent to detect Chagas. So what they do is they take the triatamine bug and one that is not infected with the parasite, and they'll attach it to the patient's arm where it's allowed to take a blood meal. And then after it takes a blood meal, they'll inspect the gut of the insect for growth of the Trypanosoma cruzi. And if it grows out they see Trypanosoma cruzi, then they know this person has been infected and has Chagas. Treatment is going to be really prolonged with these two medications, so it's going to take about 60 days to clear that infection. If you can recognize it in the acute phase, that is ideal because then you can prevent that person from progressing to the chronic phase. But after that stage, you can also go ahead and treat patients in the chronic phase with these medications, which can help curb the disease progression. But a lot of times, once they progress to that chronic phase, you're also just trying to focus on managing symptoms like heart failure and digestive problems. There's unfortunately no vaccine for Chagas, and so a lot of control and prevention is going to occur in just trying to diagnose this early, screen newborns and children of affected mothers so that you can catch it and treat it early in those individuals, and then a lot of public health measures like spraying, bed nets, and approved food storage. So for our next case, we're going to transition a bit. We're going to go to northeastern Brazil, where you're going to see a 7-year-old boy who comes in to your ER with 4 weeks of fever, weakness, and abdominal distension. His mother says he's had a poor appetite, some weight loss. On exam, he's pale. He has this really massive hepatosplenomegaly, which is highlighted for you in this photo. And then his vital signs, he's febrile, a little bit tachycardic, and laboratory studies show pancytopenia and elevated transaminases. And so if you see someone who's had this really prolonged fever, so this is not going to be a few days of fever. This is going to oftentimes present as weeks of fever and some abdominal distension with hepatosplenomegaly. I want you to think about leishmaniasis. Leishmaniasis is a parasite that's caused by Leishmania, and there are over 21 different species of Leishmania that cause infection. And the different species are associated with different clinical manifestations. These parasites are transmitted to humans by a bite from the sandfly, and there's a pretty long incubation period before people will start to develop the symptoms. So for cutaneous leishmaniasis, we'll go into these in detail in a moment. It's going to take about 2 weeks to months to develop symptoms. Mucocutaneous is going to about 1 to 3 months. And then for visceral leishmaniasis, you're looking at about a 3 to 6 month incubation period. So to start off, we'll talk about distribution of visceral leishmaniasis. And you can see that this is really is widespread around the world. There are more than 1 billion people who live in areas that are endemic for leishmaniasis and who are at risk for infection. And there are an estimated 3,000 new cases of visceral leishmaniasis that occur annually. Most of those in the Americas are occurring in Brazil. So visceral leishmaniasis is going to be, on a clinical exam, you're going to see fever, there's going to be weight loss, hepatosplenomegaly, and anemia. Also want you to think about malnutrition. These folks have had abdominal pain for some time. They might not be eating. You can see superinfections, also bleeding and liver failure, as well as shock. And it's important to recognize this and get people admitted to the hospital, get them started on treatment, because this is almost 95% fatal if untreated. Now, cutaneous leishmaniasis and mucocutaneous leishmaniasis is also really widespread around the world, and there are a lot more people that are infected and develop the symptoms of cutaneous and mucocutaneous leishmaniasis each year. And you can see that in Central and South America, we really see this throughout that area. So cutaneous leishmaniasis is going to start as a nodule that's going to progress to this painless ulcer that has raised borders. You can also see it as nodules as shown here on this person's face, or it can become disseminated where you get all these papular lesions. And then mucocutaneous leishmaniasis is going to be, you're going to see the destruction of the mucous membranes of the nose, the mouth, and the throat. You can get really substantial disfiguration from that involvement of the nasal cartilage and surrounding tissues. And then rarely you can get respiratory compromise and death from that. So in these photos, you're going to see up in the top left hand, that's a picture of septal ulceration. And then the top right, you see there's a lot of infiltration and swelling of the soft palate. You can get that deeper down into the epiglottis, and that can cause upper airway obstruction. You see this at the bottom, also involvement of the mucosal surface of the lip and the nose. Diagnosis of leishmaniasis is going to be different based on which type you're dealing with. So in visceral leishmaniasis, a lot of times this is going to initially be diagnosed clinically. So high clinical suspicion it would be someone with fever for greater than 2 weeks, splenomegaly, and who has had weight loss. If you also see a pancytopenia, that can help put you towards thinking about visceral leishmaniasis. To actually diagnose it formally, you would need to either detect the parasites on biopsy, that would be a liver biopsy or a spleen biopsy. You can also biopsy lymph nodes, but that can be difficult to accomplish, especially in resource limited settings. And then there are antibody detection tests, urine antigen tests, and PCR. PCR is probably not available if you're working in a resource limited setting, but you might have one of these other antibody or antigen detection tests. For the mucocutaneous and cutaneous leishmaniasis, you can detect this a lot more easily by doing a direct observation of the parasite in a lesion scraping or biopsy. You can also culture this out, and then if you have PCR available to you, you can do that as well. Treatment in the emergency department is going to focus around one, getting these folks connected to infectious disease, getting them started on the treatment, but also managing the sequelae of that infection. So for cutaneous leishmaniasis, wanting to do a lot of good wound care and think about super infections or superimposed bacterial infections, particularly if there's a lot of purulent drainage or there's pain that suggests that maybe this is super infected. For mucocutaneous leishmaniasis, you want to do a really good airway assessment. Like I said, this can involve the epiglottis, this can involve the airway. You can have airway compromise. If you're worried about that, get them transferred somewhere who has ENT availability. Think about intubating them if there's any signs of airway compromise. And then treatment for them is going to be the liposomal amphotericin B or antimonials. And then for visceral leishmaniasis, these patients are really sick. Fatality rate is greater than 95%. You want to give them IV fluids, transfuse if they're anemic, give them antibiotics if you're worried about co-infection or sepsis, admit them to the hospital or the ICU. And treatment's also going to be with amphotericin B or the antimonials. So moving on and shifting gears a little bit, we're going to go to our next case, which occurred in Lima, Peru. So we're coming out of the jungle and going into a more urban area. And you're going to see a 27-year-old lady who comes in with 3 days of high fever, headaches, retroorbital pain, and myalgias. She reports nausea and a poor appetite. And on exam, she's febrile, she's tachycardic, her conjunctiva are injected. Her laboratory studies show leukopenia and thrombocytopenia. And when you get a blood pressure, you notice this when you take the blood pressure cuff off. So this is going to be a positive tourniquet sign. And I want you, when you see this constellation of headache, retroorbital pain, fever with this positive tourniquet sign, I want you to think about dengue. Dengue is caused by or spread by the the Aedes mosquito, which are becoming much more prevalent in Central and South America. And the serotypes it's going to be caused by several different serotypes, 1, 2, 3, and 4. So infection with one serotype does not provide or provides long-term immunity to that same serotype and some short-term transient immunity to the other serotypes. But after a while, that is going to wane, and secondary infection with a different serotype, so if you have one initially and then are infected with two, is going to increase your risk for developing severe dengue. This is the range and distribution of dengue. So these are countries that are reporting cases, and you can see this is really common in the Americas. From 2000 to 2019, the WHO reported a tenfold surge in the number of dengue cases reported worldwide. So back in 2000, there was about 500,000 cases, and then in 2019, there were 5.2 million cases. Close to 80% of those cases are in the Americas, with about 4.1 million cases reported in 2019 in the Americas. We think this is probably because of the shifting distribution of the mosquito vector, probably due to climate change and also population growth, where people are moving into areas where they weren't previously living. There are several different phases of dengue. It's going to take about 5 to 7 days for people to initially develop symptoms, and then they're going to hit that febrile phase where for 2 to 3 days they're going to have a headache, bone pain, this maculopapular rash. They can have minor bleeding and also that positive tourniquet test. And then they're going to move into a critical phase. That occurs after the fever stops. And this lasts about 24 to 48 hours. During this phase, you can get plasma leakage from increased permeability. That's going to lead to ascites. You can get pleural effusions. You're going to see chemo concentration because of those shifts in fluid, and also these patients can develop shock. If the patient survives and moves out of that phase, they're going to go into a recovery phase where those fluids are going to get resorbed. They're going to have diuresis. The hematocrit is going to either drop or stabilize. And you can also see this rash called like the islands of white and a sea of red, which is shown on this graph. But this is not going to be how they initially present. This is going to be how you know that they're getting better. And so in this slide, wanted to just highlight that temperature drop. So as they move from that febrile phase into the critical phase, you're going to see that fever go away. And you might start to think they're getting better because their fever is going away, but actually they're hitting that critical phase where they're at increased risk for shock, increased risk for hemorrhage. And because of those fluid shifts, you're actually going to see a rise in their hematocrit rather than that drop. As they recover, that hematocrit will stabilize. To diagnosis, you're going to diagnose it based on serology, so looking for IgM. There are a lot of false positives, so this cross-reacts with other flaviviruses, including Zika and yellow fever. So if it's positive, they probably have dengue. If it's negative, it doesn't rule out dengue. There's also an NS1 antigen test. However, this is less positive in secondary infections, which is when you would really want to know if they have the infection so that you would know if they're at risk for really hitting that critical phase. This slide just highlights dengue without warning signs. And then dengue with warning signs and severe dengue. So without warning signs, they might have those initial presentations of the nausea, vomiting, rash. You can see that positive tourniquet test. But if they start to develop abdominal pain, really persistent vomiting, ascites or pleural effusions, if you see mucosal bleeding, if you see hepatomegaly, or you start to see that increase in hematocrit, this is a sign that they're in that warning period where you really need to watch them closely. These patients are at risk for developing severe dengue, which is represented by shock or respiratory distress. You can get really severe bleeding as well as organ failure. So for severe dengue, treatment is all supportive. You want to give oral hydration if they're able to drink, and you want to make sure you're limiting IV fluids while they're in that febrile phase. Because of all those fluid shifts, you don't want to give them too much fluids because they're going to start shifting fluids in the critical phase. But however, in that critical phase, if they are hypotensive, you want to give them some fluids, NS or LR. You want to monitor their urine output, but also monitor for signs of volume overload. You can also give packed red blood cells for active bleeding during this phase. In terms of prevention, there are a couple of different vaccines that are available. There's the Dengvaxia that requires 3 doses. You have to have a laboratory concerned previous dengue virus infection, because if you give this to someone who doesn't have a previous infection, they're at high risk for developing severe illness and hospitalization. The Qdenga, which is actually part of the immunization program in Argentina and Brazil, only requires 2 doses and doesn't require that the patient already have had dengue. And then there's another vaccine, the TV003, that's currently in the phase 3 trial, and there's been a lot of promise in that trial. These vaccines are not available to travelers, but you can find them more in the endemic regions. So next, we're going to move up to Central America, and we are going to be visiting an ER in Guatemala, where you see a first trimester pregnant patient who comes in with 2 days of low-grade fever, conjunctival injection, pruritic maculopapular rash, some arthralgias in the hands and wrists, but no respiratory symptoms. She has this blanching erythematous rash on her trunk and her extremities, and some conjunctivitis. And so as a lot of pregnant people are going to be coming in and worried about this, I want you to think about this and be prepared to talk to your patients about this and counsel them about Zika. So this is an arbovirus. It's spread by the Aedes mosquito and is transmitted primarily by that mosquito, but it can also be transmitted sexually. So if someone is infected with Zika, they can transmit that to their partners, and it can be spread between a pregnant individual and the fetus congenitally. The incubation period is about 3 to 7 days, and about 80% of those cases are going to be asymptomatic, so people who are not coming in to see you at all. This is a map of distribution. So all the countries in dark blue have either had a current or past Zika transmission, have recorded previous or past Zika transmission. Zika was first detected in the Americas in 2015. And if you remember back, there was that 2015, 2016 outbreak where there were more than 500,000 infections. This was the time when everyone was really worried about the congenital defects. And there was about 2,400 cases of congenital syndrome associated with Zika, mostly in Brazil. Now, the rates have gone down a lot, and this year so far, there's only been 25,000 cases of Zika reported in the Americas, but still something you want to be thinking about. Clinical presentation is pretty nonspecific, so fever, rash, headache, joint pain, some conjunctivitis, and myalgias. The main concern a lot of these patients are going to have is you might see pregnant people coming in concerned about pregnancy-related problems. It is related to miscarriage, to stillbirth, and to preterm births, and has been associated with microcephaly, hearing loss, and vision problems in infants, as well as seizures. Zika, the primary concern is going to be in pregnant patients who contract this during the first and second trimester. That's going to be primarily when you start to see these birth defects. And birth defects are seen in about 5% of infants delivered to patients who contracted Zika during that time. There are also some less common complications of Zika, so it can cause Guillain-Barré syndrome, meningitis, myelitis, and encephalitis. So think about checking for that if you have concern. The diagnosis in the acute phase is all going to be made by PCR, so you might not even have the availability to test for this, but you can test the serum, the urine, you can do CSF, amniotic fluid, or the placenta. And then in the convalescent phase to determine if they had it in the past, that's going to be by serology with IgM. This is also going to react, though, with other flaviviruses, including dengue and yellow fever. Unfortunately, there's no vaccine. For Zika. So the main thing is going to be prevent mosquito bites with bed nets or spraying of houses, and then encourage consistent condom use after someone has returned from an area or after someone has tested positive for Zika to prevent that transmission. Next, we are going to move up to the Caribbean, where we're going to be in Jamaica and taking care of a patient who is a 35-year-old female who's coming in with high fever, severe joint pain in her hands. She has wrist and ankle pain as well as knee pain. It started just 2 days ago. She has a bit of a headache, a diffuse rash, but no bleeding and no abdominal pain. On exam, she's febrile. She looks uncomfortable. Her hands are really tender, really swollen, as you see in this picture. She has this really faint rash on her trunk and her extremities, and then her laboratory tests show a mild lymphopenia. So if you see someone who's had fever just for a couple of days, really abrupt onset, and associated with all this joint swelling, I want you to think about chikungunya. Chikungunya is also an arbovirus, also spread by the Aedes mosquito, and this is only transmitted via this vector. The incubation period is about 4 to 8 days, and unlike Zika, about 75 to 95% of cases are going to be symptomatic. So chikungunya was initially found in Tanzania back in the 1950s. But then in the 2013, it was first detected in the Caribbean, and chikungunya actually translate into that which bends, referring to that bent up posture of people who have this really severe joint pain and swelling. This is a map showing distribution of chikungunya around the world. You can see it's quite widespread, but also very widespread in Central and South America. And in 2024, there were 420,000 cases reported in the Americas. The case fatality rate is pretty low. About 213 deaths were reported during that time, but a lot of cases. And this map just shows the distribution by country of cases between 2013 and 2023. You see a really high burden in Brazil, but also throughout Central South America and the Caribbean. The clinical presentation is going to be this abrupt onset of fevers, headache, nausea, and vomiting, but with the polyarthralgias and swelling. This swelling and joint pain can persist for greater than 6 months after this person has cleared the infection. You can see a bit of a maculopapular rash sometimes, but not, you don't have to have this. The rash is shown here. And then you can also see neurologic manifestations. This can also cause meningitis or encephalitis or transverse myelitis. Diagnosis of this is going to be based on PCR, so determines what kind of facility you're working at, if you even have the capabilities to test for this. In the acute phase, it's going to be PCR. In the convalescent phase, you can do it based on serology. There is no cross-reactivity, so chikungunya is an alpha virus, and so you're not going to have the same cross-reactivity with Zika, dengue, and yellow fever as you saw with those. Prevention is going to be key. So you want to tell your patients prevent mosquito bites, prevent getting this infection. There are two vaccines, however, that have been developed. Unfortunately, they're not really available in the areas where this is endemic. And so I think a lot of work needs to be done in getting those vaccines to the areas where people need them the most. And then I put together this little chart just to highlight the difference between dengue, chikungunya, and Zika to help you keep them straight. As I know there's a lot of overlap, it's hard to test for these in a lot of places. So it's difficult to know which one you're exactly treating. Treatment is often just going to be supportive though. But with dengue, you are thinking about the headache with that retroorbital pain, and then worried about more about hemorrhage in these patients, and on their laboratory findings can see that leukopenia and that hemoconcentration. With chikungunya, I want you to think about that joint swelling and fever. So joint swelling with fever, think chikungunya. And then with Zika, a lot of these are going to be asymptomatic, but you can think about that if you have a patient with fever and rash. And lastly, we are going to spend some time once again coming back to Brazil for our last case, where we are going to be in the Amazon region in an emergency department taking care of a 42-year-old female with 6 months history of progressive numbness and weakness in her hands. She has these hypopigmented skin patches on her arms and her trunk and has this occasional burning pain in her fingers. She can't grip objects well. And then sensation to light, touch, and temperature is reduced in this stocking glove distribution. She doesn't have a fever or any other systemic symptoms, though. And so if you see someone who has these patches that are decreased in sensation, I want you to think about leprosy. This is caused by Mycobacterium leprae and is transmitted via droplets. However, as opposed to in the past when we thought like people needed to be isolated and there were these leprosy colonies, you really, what we know now is need prolonged contact with a close individual for prolonged close contact with an infected individual for a long period of time. I threw the armadillo up here because this is one of the carriers of leprosy, but not a common way in which people are actually getting infected. The incubation period is very long, so it takes about 3 to 5 years to develop leprosy, and it's going to affect the skin, the peripheral nerves, and the mucosa of the upper respiratory tract. This is the distribution of leprosy. So in 2024, there were 188 cases around the world that reported cases of leprosy. There were 172,000 new cases. And you can see in Central and South America, highest prevalence is going to be in Brazil, which had greater than 10,000 cases reported in 2020. Now, leprosy isn't always going to present with those hypopigmented patches. Sometimes you can have other presentations as shown here. So starting from the left upper corner, you can get these erythematous plaques, which are with punched out areas. In the middle, you see this person who has numerous plaques and nodules. You can get nodules on the face. You can get involvement of the face where you get these lionine facies. And then you can see amputation of the finger and toes due to decreased sensation, as well as getting involvement in the upper airways with this nasal septal perforation and collapse. So management for this is often going to be done outpatient unless the person can't get to hospitals easily. Some places actually have leprosy treatment wards. Biopsy is going to be the way that you would diagnose this, and the antibiotics are going to be a really, really prolonged course lasting about 6 to 12 months. You're going to do all of this in conjunction with an ID doc, not necessarily starting in the emergency department, but something that I want you to be able to recognize if it comes in. So with that, we're going to conclude the presentation, and I just want to thank you for your attention. And lastly, just highlight the burden of infectious diseases that is increasing in this region. A lot of this we think is environmentally mediated as we see mosquitoes having wider distribution of territories, as we see people move into areas that were previously forested. We're going to see a lot more of this. We're already seeing a lot more of these infectious diseases. So I want you to be aware of these. Think about them if you're taking care of patients in these regions or if you're taking care of patients that have come from these areas. So thank you so much for your attention. I hope this is helpful and best of luck in your work out there.